Welcome everyone again to tonight's presentation, When Implants Fail, Fixing Complications in the Smile Zone. My name is Shirley and I'm going to be your moderator tonight. This evening's webinar is presented to us by Dr. David Wong. We are thrilled to have him here. Dr. Wong is a renowned periodontist with advanced training in implant and oral plastic surgery. He's the founder of Route 66 Dental Implants and Periodontics. Dr. Wong is board certified and a fellow of the International Congress of Oral Implantologists. Before we get started, we do have some quick housekeeping items to address. If you have a question, please type it into the Q&A box at the bottom of the screen, and we're going to address those at the end of the presentation. And CE is not available for this webinar tonight. And also, if you registered, a recording, a link to the recording of tonight's presentation will be emailed out to everyone sometime over the next week. Okay, with that, welcome Dr. Wong, and thank you for being with us. I'm going to pass it over to you now.
Shirley, thank you so much for the intro, and thank you to all the people who registered and hopefully are live on this call. As Shirley mentioned, I'm David Wong. A lot of you guys know me. I've done plenty of these webinars for Henry Schein, but it's probably been about a year or so since I did my last one. But today's an interesting topic. It's one that's been hot on my mind. I've been kind of lecturing about it and writing about it for the last year and a half or two. And it's when implants fail, fixing complications in the smile zone. So a lot of times, people talk about implant aesthetics and how to avoid it. But I really wanted to tackle a topic where, we have poor implant aesthetics and what do we do now? So as you guys know, I've got a couple different Instagram accounts. One is david.wong.dds. That's kind of my main personal account. And then Plaque China is my surgery account if you guys like to see surgery. So let's start off with identifying a problem. So if you guys have done dental implants before, and if you've done any significant amount of them, then you will no doubt have some failures and complications. So what I wanted to talk to you guys about today, and we're going to be flying today. We've got like 160 slides that I want to get through because I could not figure out what I wanted to leave in and what I wanted to take out. But let's go with the theme of trying to identify implants as absolute failures or aesthetic failures. Okay, so aesthetic failures, we don't like the way the implant looks. Absolute failures, that means the implant is failing and we've got to get that thing out of there. Okay, so if you are like me, every now and then this happens, right? You place an implant in the perfect position and 2 weeks later, the thing is loose and you can just reach in there and grab it with a hemostat or some cotton pliers and it just comes right out. So how do you deal with those types of things? The first thing that we're going to talk about are the absolute failures. And then the next thing we're going to talk about are situations like this where the implant is integrated, but it just doesn't look very good. So we're going to go over, these types of cases. So let's start off with managing the absolute failure. So when you have an implant that just comes out, falls out of the patient's head, the first thing you've got to do, number one, calm down, okay, and settle the patient down. We always make sure that we tell patients that nothing is ever 100%, and this does happen. We don't like it when it happens, but it does happen on occasion. But if you guys have taken my Henry Schein webinars before, the last series I did, it was a part 1 and a part 2 on the no-nonsense guide to bone grafting. And the first thing I teach you guys to do is check for a facial plate, and you just use a perio probe to do that. If you have a facial plate, then you just proceed like a regular socket, okay? Some doctors will tell you to just place another implant, maybe place a bigger size, but I'm going to tell you in the aesthetic zone, in the smile zone, you don't want to do that. You want to just treat it like a socket and graft it. So for a reminder, we've got 2 different webinars. There's a part 1 and a part 2 that I recorded last year for Henry Schein. It should be in their catalog. They're free. Just look those up and that'll be a nice review session for you guys. But if you have a implant that you take out and you feel with your probe and there is no facial plate, this is what I want to talk about today because nobody ever really talks about it. So I've got a case. This is a patient of mine that I placed this implant way back in 2007. And this guy comes in with this massive abscess, as you can see here on the radiograph. It doesn't look very good at all. And that is an implant that I placed, okay? So the first thing that you do, and when we talk about guided bone regeneration and the no-nonsense guide to bone grafting, when you look at this clinical presentation, it's really hard to tell that there's that big of a problem underneath. So when we talk about how to treat these cases, the first thing we have to do is we have to put out the fire. And the fire in this situation is that implant number 24 and the adjacent tooth number 25, as you can see here. So both of these teeth have to go. And the implant comes out pretty uneventfully, but now you're left with this situation. The question I have for you is, what do you do now? If we follow along in the no-nonsense guidebook that I did for Henry Schein, you know that there's 4 keys to successful bone grafting. The first key is we have to have a clean surface. That means we got to have clean bone, clean roots, no granulation tissue, no infection, no granulomas, no caries, no calculus, none of that, okay? So we have to have a clean surface. The second and third things we have to have is we have to have good bone graft stability, and we have to have good bone space maintenance, okay? So nothing can be squashing our graft. The last thing we have to do well is we have to suture. So when we flash forward here, you're going to see that we've placed a freeze-dried bone graft material, and we've covered it with a resorbable collagen membrane. So that gives us our clean surface, our graft stability, and our space maintenance. And then we close it up nice and neat, okay? Now, the strategy that we're going to employ, and part of the reason we're doing these webinars too, is to promote the use of CBCTs, because you've got to be able to evaluate your bone about 4 to 6 months after you do these augmentations. Now, in this situation, we opted for a single implant. Why did we do that? Well, number one is there's not a whole lot of space to do 2 implants, because remember, if you're going to do 2 implants next to each other, the ideal distance between the 2 implants is 3 millimeters. So we don't have that spacing requirement. So we chose 1 implant, and it's a good size one. This is a 3.6 by 11 millimeter long implant, and we've restored it with 2 teeth. So it's a cantilever bridge. Now, we of course do this, when you look at this gentleman's bite, we do this in areas of low force factors so that we're not, rocking and putting excessive force. Now, 4 years later, you can tell that the soft tissue, the clinical presentation, everything looks really good. Of course, the patient can always do better with oral hygiene. You can see a little inflammation there, but by and large, it's a pretty nice recovery. The one thing I would have done different in this situation, and you guys probably picked up on this, is I should have taken a CBCT before I started. Now why didn't I do that? Back in when this era situation first started, you could tell that implant's quite old. We didn't have a CBCT. It wasn't very practical, but if I had to do this all over again today, I would definitely take a 3D image. The reason that's important is because if I would have done that, I would have been able to set my expectations and the patient expectations a little bit better. I would have, let's just say I wasn't a very experienced surgeon in this area. I could have better seen if this problem matches my skill set, so I could decide whether to take on the case or refer it out. So in this case, I got lucky. I was able to keep it in my own office. And I also believe, taking a CBCT is the best time to discuss alternatives. So maybe we look at this thing and we're like, you know what, this is way too complicated, or it's just, the risk outweighs the benefit. Maybe we should just do a fixed bridge or something, right? So I think if I would have done this all over again, I would have taken a CBCT. What do you do when the absolute failure involves a soft tissue defect too? I can tell you as a periodontist, this is a situation that we see all the time, because if you go to most surgeons, a lot of people are able to replace the implant or they're able to replace the bone. But a lot of times soft tissue grafting is the missing piece of everybody's training. I would say that's the most common direct message I get is, what about soft tissue? Where do I learn more about soft tissue, and what do you do in these certain situations? So here's an absolute failure. Number 9, you can see that there's a dehiscence through the bone and the soft tissue. So the implant has got to go. I did take a CBCT. This is an older one, but you can see that the implant is very facially positioned. So we have got to take the implant out. Now, what do you do about that soft tissue dehiscence? And one thing that I teach all my periodontal residents that I get to mentor, and all the dental students that I get to mentor as well, one thing that I never do as a periodontist is give up a chance to place a soft tissue graft. So as soon as that implant comes out, which it came out very easily, I'll do a free gingival graft at the exact same time. And you can see why. You've already got the patient numb. You can see the difference between the donor site and the palate and the recipient bed is maybe what, I don't know, an inch or, maybe 2 centimeters or something like that. And so it's very easy to take that graft and just shift it over to the facial aspect. At 2 weeks, you can already see the benefit of this. You get nice, thick, keratinized tissue. It heals very, very fast and very predictably. Now, of course, if you're the patient, you're like, what's next? When do I get another tooth? So doing a free gingival graft like this gets you set up for the next step, which is bone grafting, right? So this, once again, is in a separate webinar that you have free access to. So when we talk about GBR, or guided bone regeneration, the reason that we do like soft tissue grafts to help set us up is that you have better tissue to work with. It doesn't tear. It has a better blood supply. It's easier to close. So that's why we never give up a chance to do that soft tissue graft early on. So if you look at this, we're going to use a tenting screw to give us more graft stability and space maintenance that I mentioned earlier. And then here we're using, PRF membranes, which are derived from the patient's blood, as well as some cortical bone chips from using a bone scraper from the adjacent areas in the site. You may have noticed that that patient has quite large exostoses. And then we just place our bone graft. In this situation, it's a product that we call sticky bone because we mix the mineralized cortical bone with the PRF, and we get beautiful graft stability. And then we further stabilize it with a resorbable collagen membrane. The fourth criteria that we have for successful bone grafting is nice suturing, and you can see that the suturing here is pretty good. Here we're going to start the other aspect of digital dentistry. So besides the CBCT, we also use an intraoral scanner, and we're going to get an impression, and we're going to make a surgical guide. So the importance of a surgical guide, of course, is to not duplicate the exact same error that this patient came in with. We want to place the implant in a nice restorable position that's going to be aesthetically pleasing, and we want to avoid vital structures like that incisive canal that you can see in that middle section of that CBCT. So here's our implant in place. We went ahead and placed a scan body so we could scan that for a provisional. And once again, when we're closed up, you can see the value of that keratinized tissue that comes from that free gingival graft. And then here's a provisional. And then this, I can tell you, was 2020 when COVID hit. So he actually wore this provisional for quite a long time before we were able to see him. And he finally came to see us recently for a 3-year post restoration. And you can see that he's opted, thankfully, to restore some of his other adjacent teeth as well. So we got a nice, I would say, acceptable aesthetic result, especially considering that he started here and we ended up there. Okay. So if we do it again, I want to show you the concept here because I don't believe that you guys have seen a lot of this. So if we have these failed implants, they happen quite a bit, and this actually occupies quite a bit of my time in my practice. But here we have another central incisor. It's right in the smile zone. And of course, this patient has periodontal disease as well. And now we've got this big abscess and just terrible, angry looking tissue on the facial aspect of this implant. When you take a CBCT of it, I took a photo of this because you can see that there's an abscess on the facial as well as on the palate. So this patient's in some trouble here. So we take a CBCT, and you can see in this cross section on the right side of your screen, you can see that the implant occupies a lot of that ridge, and there's really no radiographic evidence of a facial plate. So that implant's got to come out, especially when we have that much active inflammation. So with no facial plate, I tend to lean towards removing the implant. The implant comes out, and you can see that the bone graft actually comes out with it. So that bone graft is just non-vital, very necrotic bone. Just it's stuck to the threads of the implant, but you can tell that the whole thing just came out. Um, in the other webinars that we talk about selecting a bone graft material, hopefully one that doesn't die on you and doesn't integrate like this. But one of the things that we have to do, remember the rule, we try to get a soft tissue graft in early. So when you take that implant out and there's this gigantic hole, you don't have to necessarily plug it in with bone right now. We can actually do a soft tissue graft. It's very, very predictable. So here what we're doing is I'm just roughening up, the chronic areas of inflammation so that we can get some fresh bleeding points. So that's what I'm doing here. And we take that free gingival graft, from the right side of the palate, and then we contour to basically to shadow the exact defect size and shape, and then we suture it into place. 2 weeks, you can see how rapidly these grafts heal, and this is just one of my favorite techniques to do this, because we kill two birds with one stone. We get rid of the implant and we reestablish a nice soft tissue ridge for the patient. So by 12 weeks, we can now, consider our bone grafting options. And in this situation, what I don't like about her case is that when that implant came out, or even prior to, she lost a lot of bone that we couldn't gain back vertically. So when we open the area up, we got the 4 rules of bone grafting again. Clean surface, that's a clean surface. I don't see any signs of disease or granulation tissue or anything like that. We put our bone graft in and cover it with a resorbable collagen membrane. You can see that tacking suture or periosteal anchoring suture is providing us with plenty of stability, space maintenance. And then we close, okay? The 4th thing is we have to have nice suturing. She's going to come back 2 weeks later, and you can see how plump that ridge is. Everything is looking really, really nice at this point, so that we can now do our implant, with a surgical guide, which of course entails using an intraoral scanner as well as a CBCT. And then we place our implant flaplessly. So that way we can reduce the amount of trauma to the patient. And then you can see the implant is placed more towards the cingulum so that we can have a screw retained provisional made. And I'm a periodontist still. I don't do the final restoration, but I do like to help out my docs to get them set up. So what I wanted to point out for you guys, if your specialists aren't already doing this, encourage them to if they have time. But I frankly enjoy this part of it. So we've made a provisional first, and to try to train the tissue, because this is a pretty complicated case in the smile zone. When we tried it in, it was really blanching the tissue, and we don't like blanching, because blanched tissue, especially if you have thin tissue, means that it's got a high chance of recession. So we don't want to do that. So what I did is I took it back to the lab. Actually, I marked it with just a pencil, marked the gum line. And what I did is I communicated to the lab that anything apical to that line, we want to reduce that and make it concave. So that's what she's doing here for me right now. She's just going to make the neck of that provisional nice and concave. This is just a provisional restoration, and here we are. We're going to wear this around for a little bit, and just to help let her just be happy and get rid of that Essex retainer that she was really not liking. And all we're doing here is just training the tissue and setting her up for future success with the final restoration. So the shade's obviously off with the provisional that I've made. I'm not making a huge effort to try to match the stains and the crazed lines and all that stuff, because ultimately we do want them to see their dentist for the final restoration. So they don't want to see them. I don't want to see them in a provisional for like 2 or 3 years or something. So how do we manage implant aesthetic failures that are not absolute failures? Now, this is kind of where I really like to have a lot of fun. So one thing that we've got to talk about is, why does this happen? So if you have been around implants long enough, even if you place them or just restorative, I know you've seen these, right? Where patients smile and you can see the abutment. And I know you see them a lot on posterior teeth. When they happen on posterior teeth, we don't really care that much because we're just like, nobody really sees it. It's healthy. There's no pocket. It's fine. But when it happens on a front tooth, now it's a big deal. So the question that I have for you is, why does this happen? So when it happens, I can tell you from numerous personal accounts, everybody kind of blames everybody. The surgeon's blaming the restorative dentist is blaming the surgeon. Everybody's pointing at the lab. Patients like, what did I do wrong? So the reason these things happen is that there's lots of things that go into recession around an implant. A lot of it has to do with the implant position. A lot of it has to do, as I just showed you in my most recent example, has to deal with the abutment and crown design. Some of it has to do with patient factors like their periodontal phenotype, whether or not they have thick or thin tissue, or whether or not they have keratinized tissue. Okay. So let's talk about immediate implant placement first. I would say whenever I'm answering my messages, the majority of the time that people have trouble is with an immediate implant placement. And why is that? We have been taught, and it's been beat into us, at school and social media, that when you take a tooth out, your best chance at cosmetic success is to stick that implant in at the same time. Unfortunately, it's not always that easy. It's very easy, however, to place it too far to the facial, as you can see here in these 3 examples. And that, of course, leads to just disaster when it comes to implant cosmetics. So if we look at the outcomes of extraction sites and implants that are placed immediately into these extraction sites, I love this article from Stephen Chen and his group because they reviewed several studies and they looked at not only implant survival, but they also look at recession. Because hopefully by now we're beyond, thinking that implants are experimental or that they don't work. We know they work, but I'm trying to figure out now, why do they recede after a certain number of years, or actually after 1 year? We know that if you take out a tooth and that socket has 4 walls of bone and you place an implant in there, that's actually a very common situation where you have recession. And the reason that is because a lot of these patients, we don't necessarily assess their gingival phenotype, right? We don't really look at that. We look at the bone, right? That's all we're looking at. But if we stop and pay a little bit more attention to the phenotype or the biotype, that's when we can start identifying, which of these cases are going to recede and which ones are not. So risk factors for recession around an immediately placed implant include having a thin tissue biotype or phenotype, too facial of a position for the implant, a thin, damaged, or non-existent facial plate. Okay, those are the risk factors. They also noted in this review article that early implant placement, in other words, if you stage it, you do the socket graft first, like I talk about in the other 2 webinars. If you do that first, you actually have less chance or less frequency of recession. When we look at this paper again, what I found was interesting. This is the same group of people, but a different paper. They looked at several articles again, and they found that with immediate implants, meaning you take out a tooth, you put in the implant at the same time, it's crazy to see this, but the range of recession of 1 millimeter recession or more ranges from 9 to 41%, 1 to 3 years after placement. So that's kind of a big range there. If you place an immediate implant, 9%, some papers had 9% had recession, some papers had up to 41%. And the reason that for the variability depends a lot on the operator and who's doing the implant placement. The thing they noted, though, that was very, very common is that when you take a CBCT, you don't see a facial plate. And I thought that was really, really interesting. Once again, having thick tissue and a facial plate helps you reduce that aesthetic risk. So if you want good long-term implant aesthetics, We have to think about putting the implant in the proper position. We have to think about having thick tissue and a nice, thick facial plate. This is not a comprehensive list. I've only got an hour with you, so this is my 3 keys to maximum implant aesthetics: proper position, thick tissue, thick facial plate. Now, the question for you all is, how do you tell if you have, how do you get that implant position, and how do you tell if you have a facial plate? Well, of course, you have to have a CBCT. So I think now, hopefully enough of you guys are on this call. I want to just have Shirley pop a poll up here, and let's see how many of you all have access to a CBCT. Just wait a few seconds here while you guys are logging in your yes or no answer. I can't see the results, but Shirley, just let me know when we're ready to move on.
Okay, and it seems like we have about 20 more seconds. Answers are still coming in, and I will be going to publish these results in T minus 10 seconds.
So I think this is like very promising. 78% of you, own a CBCT. And I think that's really, really cool, because I can tell you when I started practice, the answer was like 1%. We used to have to send our patients to the hospital and send them a long list of parameters on how to scan, use their medical CBCTs, medical cone beams to translate into dentistry. So times have definitely changed for the better, and almost 80% of you, almost 4 out of 5 of you guys, have a CBCT. So a lot of this information that I'm giving you, at the very least, if you're not going to do the case, you can at least, play a huge role in diagnosing. So let's talk about some of these cases. So this is where I personally have fun, problem solving some of these implant aesthetic cases. So this patient was referred to me from an oral surgeon's office, and he had placed an implant for tooth number 11. And he noticed over time that, oh crap, the gum tissue is just receded on the around this healing abutment, and he didn't know what to do, because, like I said, a lot of people are great at placing implants, or even using a guide with their CBCT and placing an implant in the right spot. I think this implant's in the right spot. But everybody, a lot of people have trouble, managing the soft tissue. And then this was the case with this particular surgeon. He said, I got the bone, I got the position, but I just don't have the soft tissue. What do I do? The challenge in this situation is the tissue is poor, right? We have high freedom attachments. We have no keratinized tissue, no attached gingiva. It's not just thin, it's like non-existent. It's not there, So if the dentist were to try to restore this case, they'd end up with a huge canine. So one of the things that we do, if you're still in the healing abutment phase, the smartest thing that I can advise you to do is just take the healing abutment off and put a cover screw on. And by doing that, that's a process that we call decoronation. That's I believe Tarnow and Stephen Chu first coined that. I could be wrong, probably am wrong, but that's where I first heard it. So you decoronate the implant by taking off the healing cap, putting on a cover screw, and you wait 4 weeks. You can wait 8 weeks. You can wait however long. In this situation, I briefly thought about taking out the implant, but I was like, you know what? It's like partially, into the through the sinus floor there. I don't think I want to do that, right? So we opted not to do that and to save the implant instead. So this is where I get to play periodontist. So we took 2 grafts. The top one you can see is a connective tissue graft. The bottom one, which is whiter, is a tuberosity graft. So it comes from the maxillary tuberosity. And the reason we use this tissue is because you could see how much of that defect was so concave, and we also needed some vertical height as well. What I did is I snuck the connective tissue and the tuberosity graft on through both sides towards the defect. One way through the frenum and another way through a incision that I made between the premolar and the molar. Okay, so we drug those grafts into place. You can see that incision line in the palate. It's very, very thin, and it heals up beautifully and quickly. But the patient left my office looking exactly like this, with it all built out, like you can see here. Now, I will say this: the challenge in her case was those frenum pulls, okay, because those frenum pulls were working against us the whole time. So after 8 weeks, I've made a provisional for the patient, and this is the provisional. It's not the nicest thing in the world, but it's doing the job of training the tissue. So what you can see here is everything's looking pretty decent, but we've got some black triangles, right? So a lot of times people are like, what do I do about that? Do I send it to the periodontist? What's he or she going to do? We're going to do nothing, and we're going to we're going to do nothing. We're just going to watch this, and that's because that's the purpose of provisionals. Because over time, what we'll see is that 18 months later, that those papilla, they do tend to come back in the presence of good interproximal height of bone. So here's our before, and here's our after. Now, if we look at the papilla from the left to the right, from initial presentation with the healing cap, as we go through the provisionalization process, you'll notice by 24 months, when the patient just lifted her lip up and took a selfie for us, the papilla are mostly there. And that's just science, okay? That's just from Yuli Grunder's old article that says the papilla volume increases an average of 0.375 millimeters after 1 year. And that's been duplicated a few times. That number floats from between 0.375 to 0.4 to 0.5, but it's somewhere within the realm of at least half a millimeter, which when we're talking about papilla, that's a lot. So here's our before and here's our after. Now, what happens if you don't catch it early? Okay. And I kind of want to talk about this case a little bit more. So I get an email from one of my friends who owns a lab, and he's sending over this picture of a young lady whose case he has in his lab right now. And the email that you're seeing here is coming from the restorative dentist. And the restorative dentist asks my lab friend, do you have any suggestions for blending the gum line of the crown to the other teeth? Question mark, gingival colored porcelain, question mark. So this case is in the lab, and they're thinking the best they can do for this poor girl is pink colored porcelain. These are the photos that the dentist sent to me, and he did not place the implant. He inherited this case as well. So when she's smiling, you can see not only the abutment margin, but you can also see how the tissue is concave and very thin. And overall, we don't need to try anything in. You can tell that it's not going to look very good. So this is her present situation. I agreed to see her for a consultation. And you can see that this is what she looks like. It's a crazy long lateral incisor. You can see the abutment margin. You can see that there's inflammation around that margin. And this is her, and she is just the sweetest person ever. And she smiles like this despite this tooth, right? She's just a happy person, which is, I think that was what made this whole thing work in the first place. When you see the occlusal view, you can see that concavity over that lateral incisor. And radiographically, it doesn't look bad, right? You take a PA, the implant is dead center, and there's no bone loss around it. You take a CBCT, surely the implant's through the facial plate, but no, it's not. It's right in the middle. So what do you do in a situation like this, right? So here, if we look at her, she's got a facial plate. She has good interproximal height of bone. She does have thin tissue, which we talked about, right? We want thick tissue. It is keratinized, so that's a good thing. The papilla, kind of narrow, and they're sharp and pointy. So that's going to be hard. And the prosthesis design, I would say, is poor, right? We look at that, we just know the prosthesis design is not good. Her overall smile, she shows a lot of gum tissue, right? Whenever she smiles. And what she's got going on is vertical maxillary excess. She's got altered passive eruption, maybe some altered active eruption as well. If you guys are unfamiliar with those terms, once again, I've got a Henry Schein webinar on that. It's under the crown lengthening. I believe it's called either the A to Z, the crown lengthening, or the no nonsense guide to crown lengthening. But with this information, we have to decide, are we in or are we out? And being a periodontist, I can't think of anybody else that I would refer her to. So I went ahead and said, count me in. I'll sign up for this. The challenge with this person is that with this sweet young lady is that she's only been given 2 treatment options in the past. And because I was not the first person that she consulted. You could either remove the implant, which hurts a lot, it's expensive and time consuming, or what we just talked about, decoronation. And she didn't like either of those 2 options, and neither did I. Why don't I like those options? Well, for her, she's never known anything but having a tooth there. She's never, her implant was placed immediately, and she had it in immediate provisionalization. She's never had a flipper. She's never had an esthetics retainer. I didn't want her to have to go through that because, she's a young mom. She's cute. I just didn't want her to have to do that. So I was trying to bang my head around, trying to think of ways that we could avoid removing the implant or getting her back into an esthetics retainer or a flipper. Now, I remind you guys, everything that I'm showing you, I have a reasonable expectation that this is going to work out. I don't cross my fingers and just hope things happen. So the questions that I had for myself is it possible to be practical? Can we avoid going back to a removable prosthesis? How do we minimize the number of appointments, and how do we minimize her pain? So the first thing that I did is I beelined straight to the lab, and they already had her abutment, milled out and designed. And I looked at it, and one of the things that we try to do with all of our implant crowns in the smile zone is we want to make sure that we have a flat or concave facial contour. So that blue mark that you see in the middle of your screen, those are from me. I just grabbed a Sharpie and I just told the lab technician that I wanted all that just shaved off. And to the right of your screen is kind of what you can see was the result of that. The reason we do that, this comes from a paper written by my friend, Dr. Dean Vafiatis and his colleagues. Dr. Dean, great. He's also a great account to follow. He's a prosthodontist in New York City. Good friend, great prosthodontist. But what he talks about in this very brief paper is that when you shave down, for every millimeter that you shave down on the abutment horizontally, you actually gain vertically about 1 millimeter as well. That's kind of the big lesson there. So you can see the abutment on the left, the original one, and then the modified one on the right. So when we talk about the surgery, it's actually pretty simple. What we do is we went ahead and took off her old abutment, and you can see how big that soft tissue defect is. It's very, very large. And what I did after that is I went ahead and took a tuberosity connective tissue graft, and that's what you can see here. We just go to the tuberosity and we just grab a piece of connective tissue back there, and there's no finessing that. You just grab a 15 blade or a 12B blade, and you just remove that tuberosity. And this is the result here. It's a nice thick graft. After you take the epithelium off, it conforms, or it forms to the recipient site of the lateral incisor just perfectly. It's got that perfect curvature. And that's because you're taking off the tissue from the distal of that second molar, so it fits great. You can also notice that I access where I'm going to place the graft is through the frenum, and I love the frenum. That's my favorite spot to go, and we'll talk about that now. So the flap design is not something that I invented or developed, but is something that I named about a year ago, last September, in September 2023 to be exact. And inside the industry, you can read about this. The name of my paper is called Periodontal Surgery to Correct Gingival Recession. And I use this to treat recession on implants as well. And what I talk about in that paper is going through the frenum. So it's a frenum access, okay? And then the other premise behind working around front teeth when you're doing delicate soft tissue grafting is you don't want to reflect the papilla. So we're going to tunnel under the front teeth. Back teeth are different, right? Back teeth, we aren't as cosmetically demanding. And also, like in this photo here, that's also where all your abfractions are. So you have to have access to that so you can smooth them down, or if they've been restored with composite, you have to be able to reshape those or remove them completely. But the name of this flat design is called the frenectomy anterior tunnel sulcular access channel. Okay. I jokingly called it on Instagram the fat sack. So that's just something that I came up with as a joke, but it did turn out to be published. So the fat sack technique is something that I do a lot for root covered surgery, but especially around implants, because the last thing you want to do is reflect the papilla around an implant, because that could lead to some trouble in the name of bigger black triangles or even more recession. So we don't want to reflect the papilla around an implant. I love this fat sack approach. We go right through the frenum, and we're going to tuck that connective tissue graft right over that tooth number 7. Here is what she looks like after we sew up the frenum. And then you can see we've also done a little bit of crown lengthening on the adjacent teeth as well. This is what she looked like at 3 weeks. And you can see from the occlusal view how thick that tissue is. It thickens up very, very nicely with those connective tissue grafts from the tuberosity. And then here we are. She still has her sutures in place. At 8 weeks, this is what she's looking like. And here she is at 1 year. And then here she is recently just taking just to check in with us. And then she brought us some donuts, and we got to meet her daughter the last time she was in. But as we go through this progression, you can really see the difference in where she started and where she is. And our most recent picture together is here. So the question, in these situations is this practical? Is this painless? Is it predictable? And I would say I can't think of a more practical way to treat a defect this big. It is relatively painless because you don't go to the palate. The tuberosity hurts way less than going to the palate, and it's very predictable once you know how to design the prosthesis and what your gingival grafts can do. Henry Schein had asked me to do a little bonus sinus tip, because that is one of the most widely searched of my webinars, is the situation sinus webinar that you can look up as well. But in that webinar, this is what you're going to see. So we've all been in situations where you've seen an implant perforate a sinus. Maybe you did it, maybe somebody else did it. But the whole point of it is you don't want to leave half your implant or more sticking into the sinus, because as you can see on the right side of your screen, that can lead to some pretty bad infection. And infections, when you see some white milky substance, that's going to lead to more bone loss, right? So what I wanted to share with you is this. When that happens, take the implant out. Okay, it should just come out almost like a baby tooth. And you want to reflect the flap. You want to make sure you clean the area, right? You have to have a clean surface. But as far as materials go, this is where materials do make a difference. BioHorizons, who's owned by Henry Schein, by the way, they make this product. It's called a Mineros X plug. It's very similar to a Kala plug or a Hella plug. The difference is that it's infused with some bone graft particles that are bovine, okay? And all you do is you grab this, and after you clean everything out of the sinus area, you just basically just cut a little bit of the tip of the Mineros X plug, and you're going to place it, halfway into the sinus, halfway out. And then you're going to proceed and follow the GBR protocol that I've showed you before with the freeze-dried bone covered with a resorbable collagen membrane. Okay. And once you do that, you'll take an x-ray immediately post-operatively. The benefit of that Mineros X plug is that it's radiopaque. So you'll be able to immediately see what you've done for this patient. And then after 6 months, there's no shortcuts. You still have to wait 6 months for any type of a sinus graft. You'll be able to take your CBCT, and you'll notice here that you have look at the right side. You can see that nice dome of bone. That's plenty wide, plenty tall for a new implant that you can see here. We'll take a radiograph halfway through to make sure we're on the right track. There's the implant placed into our grafted sinus. This is what it looks like 4 months later and 1 year post-operatively. Okay, it's not the best thing, best case I've ever done in my life, but I would say, considering that somebody had placed that implant so far into the sinus with a pretty bad infection, this patient was really thinking they were going to have to do a bridge, and they were really happy that we were able to do an implant. For the next 3 minutes before we go to the Q&A, we're going to talk about the big lesson. Okay. So the big lesson is, for the 78% of you that have CBCTs, use them. You want to use them. You don't want to overuse them. I'm not saying, use it for endo and take a working length x-ray and, keep doing them every 10 minutes. But I am saying use it for your diagnosis, use it for your planning. And when you have a complication, you definitely need to use it, because that's how you confirm, whether or not you can fix something, whether it's in your wheelhouse or your skill set, or if you need to refer it. It helps you, like I said earlier, set the expectation for patients, and also helps you assess the how to proceed, moving forward. Are they free? Are they done? Can they go back to their dentist? Do you still need to monitor them every 6 months, or whatever that may be? You want to be able to use these CBCTs to help you make good clinical decisions. Now, final quiz. Okay, so we've got 90 seconds left. I want to ask you guys, is this an absolute implant failure, or is this an aesthetic failure? This patient comes in, and his chief complaint is he is in a provisional restoration that he hates. Okay, the patient had an implant placed. He had an implant removed. He had a tooth removed and an implant placed. Same day. Okay. After it healed, the dentist put a provisional restoration on it, and that provisional is what you can see here. The scarring above, we got to get to this is what he looks like when he smiles. The scarring that you see above happened after he saw a periodontist to do a soft tissue graft. He wasn't sure what type of a graft he had done, but he knows he had a graft done. And this is what he looks like with the cheeks retracted. So my question to you is, this patient comes in with the temporary that he doesn't like. You can see the clinical situation. Look at the soft tissue above the gum line, or above the implant number 8. Look at the adjacent papilla. Look at the tooth size discrepancy. My question to you is from what I just told you, is that what you would have done? And what do you see now? For me, I can tell you, I see that implant's pretty big, pretty long, and you can see the gray sticking out, above into the mucosa, into the labial mucosa on the facial aspect. My question to you is, what other information do you want? Hopefully you guys are like, well, we need to take a CBCT. So what does that look like? When you take a CBCT of this implant, this is what it looks like. Now, once you see this, I've got to ask you, would you have proceeded to do a soft tissue graft, knowing what you know now? And now this is the slice of that implant. So would that have been appropriate? So my question to you for your final quiz today is this an absolute failure, or is this just simply an aesthetic failure? And if you answered absolute failure, I would say I agree with you. So did you get it right? With that, it is 7:50 on the nose, and it is time to go to our Q&A. So if you guys have any questions, I'm happy to answer them. And as usual, follow me on Instagram, and I'm always receptive to the messages there too. But thank you guys for being here tonight.
Thank you so much, Dr. Wong. That was awesome. And just for the record, I answered that correctly as well.
You go.
Absolute failure. We do have a lot of questions that have come in, so let me get those started. This one from Jason Hirsch. What is your bone graft of choice to regenerate a ridge, and what membrane specifically, the brand?
Yeah, so bone graft, I'm not really particular about any of them. I always advise doing a mineralized cortical bone. Okay, the two brands that we have in the office is one is called Mineros and one is called Symbiose. One is a BioHorizons product, the other one is a Dentsply product. As far as the membranes go, the membranes that you saw here today, there was two different ones. One was an Osix Plus membrane from Dentsply. The other one was a Memlock membrane from BioHorizons.
Okay,
And both,
great.
both
Oh
are
yeah.
resorbable. I'm sorry, both of those are resorbable, by the way. So
Okay, thank you. This next one from Jeffrey Wan. Ever since I got the CBCT, I've noticed a lot of patients have thin facial plates. What sort of magic procedures do periodontists use to enhance the available bone, especially in the anterior maxilla? Thank goodness I do zero of these implants.
Jeff's a good guy. So we actually keep in touch through Instagram. So when you have thin facial plates, then what you're observing is exactly right. About 86 to 87% of all facial plates are less than 1 millimeter in thickness. So what we do is, number one, that influences where we place our implant, which is mostly more to the palatal side. But if we do have to augment it, there's several different techniques for that, but most of them fall under the category of guided bone regeneration. And that, fortunately for you guys, is a Henry Schein webinar. It's in part 2 of the guided bone regeneration webinar series we recorded last year.
Thank you. This next one from Warren Jones. Do you prefer zirconia abutments for better peri-implant health in the aesthetic zone? Any pros or cons of using it as well? Thank you.
Yeah, I think zirconia is fine. I think gold anodized abutments are great too. I think gold's probably more what I have more experience with. It's very aesthetic. It really is masked very nicely by the overlying ceramics. Zirconia is fine too. The only problem with those is sometimes you have to worry about breakage and how they're handled in the lab. But I would say, most of the zirconia that we do like has a metal base to it, so it doesn't fracture and so it fits a little bit better as well. But that's a periodontist perspective there.
And this next one from Mohammed Atia, is that the same crown? I think this question came in the middle of the presentation. So I'm not sure, Dr.
I,
Atia, if you could, yeah.
I bet he's talking about the last case with the woman that we were having with the lateral incisor. It's a different crown. So we changed out the abutment and also changed out the crown. So it's a different restoration entirely.
Thank you, Dr. Wong, and thank you, Dr. Atia. This next question from Prince Dylan. I just said wow out loud when I saw the number 7 tuberosity CTG. Well done.
I appreciate that. I appreciate
This
it.
next one, yeah, it's impressive. This next one from Adrian Acosta. Any concerns with hypertrophy of the tuberosity grafts?
Yeah, so you'll read in literature that the hypertrophic, connective tissue grafts from the tuberosity. You'll read about that every now and then. I do believe that does happen. I have not had it happen to the point where it bothered a patient. So I have seen it, but it has not been to a point where a patient has ever asked me to do a revision.
Thank you. This next one from Francisco Perez. Can you describe the epithelialization of the tuberosity graft? Hope I pronounced
Super
that right.
easy. So the intent of all of doing a de-epithelialization is to remove the epithelium. You can do it one of two ways. You can either do it with a high-speed diamond, okay, and just be careful. If you guys follow me on Instagram, you saw the day that I lost it and stepped on it with my shoe. So you don't always want to do it that way. The easiest no-fail way to do it is just to use a fresh scalpel blade and just remove the surface epithelium, keeping in mind the surface epithelium is only like 0.5 millimeter thick.
Great, thank you. This next one, if we weren't able to see buccal plates on CBCT sometimes, how do you create a treatment plan for immediate implants? How can you predict if there will be a buccal plate after extraction or if there won't be?
Yeah, so usually if I have if it's very, very poorly visible the buccal plate's very poorly visible on a CAT scan, then I'll prepare the patient to stage the approach, unless they have an abnormally wide ridge that we can really place the implant to the lingual side. But I would say if you're a beginner or intermediate, a good rule of thumb is that no buccal plate, no implant at the same time.
Thank you. And this next one from Vincent Eng. So the main concern with reflecting a flap in the anterior is losing blood supply to that peak of papilla bone, possibly leading to larger black triangles.
Yes. So you can lead to larger black triangles. Keep in mind your interproximal height of bone around implants is typically a little bit lower anyway, or more apical anyway. So you have to be very, very, very careful. You have to prepare the patient if you're going to do that, that you might lose lose the papilla. And in situations where you have peri-implantitis, you may not care because the patient just wants to keep the implant. But when you're talking about smile aesthetics, that's a different bird. You definitely want to preserve the aesthetics of that case by not reflecting the papilla if possible.
Thank you. This next question from Yang Basei Dong. How do you soft tissue graft number 8 or 9 when lacking of keratinized soft tissue?
Yep. So there's one of two ways you can do it. You can do either a connective tissue graft from wherever you want. I like the tuberosity. But another way would be using a palatal connective tissue graft. Um, if you just want keratinized tissue only and you're not worried about anything but keratinized tissue, you can also use a free gingival graft where you take the full thickness of the epithelium and the submucosa underneath.
This next one from Dino D. Would you replace a loose implant with a wider implant on the same day after removing the implant and cleaning the socket?
If we were in a non-aesthetic area, I would do a larger size all day long. But in the aesthetic zone, I don't do that because bigger implants typically lead to disaster in my hands when we're talking about the smile zone. So I'll usually just wait, graft it, and then come back later with the same exact size implant.
This next one from Ahmad N. Do you try to get primary closure for resorbable membranes?
Yeah, so it depends on the situation. For extraction sites, a lot of times I don't get primary closure, but if we're talking about bone augmentations and atrophic ridges, then I always 100% of the time get primary closure.
This next one, how would you fix that last case from Martin Marderosian? How would you fix that last case?
Yeah, so the last case, in a situation like that, fix it basically like one of the earlier cases that I showed you in the webinar. It'd probably be the second or third case, or even both of them apply. I take the implant out and let it heal up, let the soft tissue grow in, and then do a guided bone regeneration, let that heal, and then proceed to implantation and the final restoration like normal. But it's all
This
starts with removal of the implant.
this next one from Warren Jones. Do you like Fibogide as a substitute for soft tissue grafting?
Fiber Guide, soft tissue grafting. I have not used it, so I really can't speak to it. Yeah, I'm sorry. I haven't tried it.
This one again from Jeff Wan. David, it's been such a pleasure seeing you speak. This is Jeff, your bald Asian brother from another mother, all the way in Sydney. Good to see you,
Hey, cheers. Cheers, my awesome buddy.
mate. And then this next one from Ahmad N. From Minoros X plug, can you insert in socket and do cross suture without membrane?
You absolutely can. Keep in mind because it has xenograft in it, it takes a little bit longer to resorb. So by long, those particles can last up to a year. So be careful if with your intent on that. It does fill a space in a socket very, very well though.
This next question, when do you suture to fix membrane? When do you screw?
Okay, so typically I suture. Okay, I'd say 90% of the time I like to suture to fixate, excuse me, to fixate the membrane. Um, Screws work really, really well for space maintenance to keep your graft from being squashed. So if I really feel like I'm in danger of compressing the graft, then I'll use a tenting screw. But I'm not. I'd say 90% of the time I just use the sutures like I showed you here.
Great. And doctor, we have about another 20 questions that have come in. We are at the top of the hour. Would you like to continue or
You
would
know
you
what?
like to?
I'll hang out as long as everybody wants to. Yeah, as long as
Okay,
you guys
great.
don't care, I don't mind. I don't mind. I'm
Great. Wonderful. And this next question is from Alyssa Hansen. How much torque value do you think is required in order to place a provisional?
Um, so the answer to that, actually, it's funny you should say that. Actually, just was working on our presentation. The average torque value it ranges, but some people say 50, but the reality of it is it's closer to 30.
Great, thank you. And this next one, can you explain how you use OsseoPlug to plug sinus perforations again, please?
Yeah, so it's called so for the sinus perforation, this is what we're using is um, already kind of brain farted there. It's the Minoros X plug. So after you take out your implant, or if you even have a small perforation, let's just say after you extract an upper molar, all you do is you just take a small bit of just cut the tip of the Minoros X plug because it's quite large. You just take the tip off and then you just plug it into your perforation to where part of the material is into the sinus and part of it is into the socket, and then you just graft the rest of the socket like normal.
Great, thank you. From Abdullah Alani, if you were to de-epithelialize the FGG prior to placing it when extracting the implants, would it make it different aesthetically?
Say that one more time. I'm sorry. If you were to
Oh yeah,
de-epithelialize,
no problem. Yep, the FGG prior to placing it when extracting the implants, would it make a difference aesthetically?
it would look better aesthetically, for sure, because you'll have a better color match. But it won't be near as keratinized. So it depends on what you want, color match versus keratinized tissue. In theory, it should be the same, but it has a better color match because it acts more like a connective tissue graft.
Great. I missed that part anonymously from Dino D. I'm not I'm not, Dina, if you could let us know which part you're referring to in the comment below, that would be great. This next one from Maria Lynch. Thank you for the very interesting presentation. How can I check the webinars at Henry Schein? One way is to go to the Henry Schein YouTube page and to do a Google search for the names if you're looking for something specific that Dr. Wong mentioned earlier from his previous presentations, to do a search for his name and the name of that presentation and or some keywords from the presentation, and then you should be able to find it on YouTube. Okay, this next one from Paul Meekley. Do you use any special instruments for your fat sac tunneling?
I don't. I actually have the smallest armamentarium of anyone. I use a number one Woodson. I use a 4R4L elevator, and then I use a Pritchard elevator. Those are the three things that I use.
For that case with the frenum, the vestibular graft. Oh, okay. This is Dr. Mohammed Attia. That case he was referring to before, it was for the case with the frenum vestibular graft.
Okay. What did he want to know? I'm sorry. So
And let's see, and I think he wanted to, doctor, if you could just put the question in, that would be great with the full question. That would be really helpful. Thank
I'm
you.
so sorry. Yeah, and there
No,
was a
I'm so
couple
sorry.
yeah, there was a couple of vestibular grafts in there too. So, but
Okay, we'll
I'm here.
see. We'll see if it comes in. Okay, as soon as it comes in, I will let you know. Let's look at the bottom to see if it's coming in. It has not come in. If you could let us know, Dr. Attia, that would be wonderful. Do you use any synthetic soft tissue graft?
I do. So whenever I'm grafting teeth, never implants, but I'm grafting teeth, I use a couple different products. I use Alloderm from BioHorizons, and I also use Perioderm from Dentsply. Either one of them, it's just whatever I pick up. I love them both.
Cool, thank you. This next one from Jessica Lau. What benefit is there to doing a bone graft after tissue graft when dealing with absolute failures? Why not do PRF while doing a tissue graft in three
So
in one?
yeah, so if you're going back, for an implant to replace an absolute failure with another implant, 9 times out of 10 or 19 times out of 20, even, you're going to need more bone. So the soft tissue just makes it easier for you to do your bone grafting. Whenever you do the PRF, keep in mind what the benefit of that is. You can use that as either to mix with your bone graft material to make sticky bone. Some people just use it over a wound to accelerate soft tissue healing. So just keep in mind what your intention is there. But to answer the big question is, you always want to add bone in those absolute failures, because when the implant comes out, it's going to leave a defect.
Great, and I did find Dr. Attia's question. Is that the same crown? Is that the same crown
Yep.
for the case with the frenum vestibular graft?
It's a different crown. Yep, it's a different crown than the one that she presented with. We had to remake the crown at the time of the. We did deliver that crown though at the same time as the surgery.
Great. This next question, can we get the recording of this presentation? And yes, everyone who registered will be receiving a link with the recording, and that's going to happen sometime in the coming week. So you will be receiving a link to this presentation so you can watch it again. This next one, would you screw retained crown with ASA screw on that case number 7?
Um, A to say, oh, angle screw access. No, that one was just cemented. It was too far to the facial to be able to do angle screw access. Sorry. Yeah. I had to think of what ASA stood for.
Thank you. This one from Martin Marderosian. How do you manage burnout on the CTR when taking CTs of implants?
Yeah, so in that situation, look at you'll have to talk to your technician and look at the specs. The ones that we have ways to diminish the not the burn not necessarily the burnout, but also some of the shielding from the metals and other implants and root canals and crowns. So that's something that you'll have to contact your manufacturer on, because they have ways to uh, to filter that out.
Thank you. This next question, if there's recession around an implant in the anterior zone, do you ever consider proceeding with decoronation without planning a soft tissue graft?
Yeah, that sometimes I do, but I would say a lot of times, even when you decoronate and stick a cover screw on, that hole never fully just completely closes. You can always, it's still small enough or big enough to where you could get a probe in it. And I would say if I leave it long enough, there's still a little bit of exudate that comes out of that little hole. So I usually plan for further grafting.
Okay, thank you. This next one from Jason Hirsch. To stabilize your soft tissue graft through the tunnel, are you stabilizing the graft internally with a sling suture or just picking up the graft with the external closing suture?
I only use that external closing suture for me personally. A lot of people do it differently, but that's the one or two sutures that you saw. That's all I do. I just go in through the external part of that tunnel flap, grab the graft, and then tie a knot on the facial. So I'm known for being a little simple.
Fat sac versus semilunar in the vestibule. Any difference in the outcome?
I like fat sac better for me, just because the frenum is mucosa and it stretches, it's easier to close. Whereas semi-lunar scares me sometimes, especially when I didn't have a CBCT or I didn't know how to read them. Because if you use a semi-lunar incision and you don't close it, or if there's a exposed root or implant or something under there, I do worry about that. And also, I don't. Whenever you do a semi-lunar, that's directly over your regenerative materials like your bone grafts and your membranes. Just makes me a little bit nervous in case it opens up. So I like to go through the frenum.
And this next question, for Memlock resorbable membranes, do you worry about the membrane degrading too soon if this is not primarily closed?
No. So usually when I use it for in non-primary closure situations, I'm almost always using them on extraction sites to where you have a lot of acute wound healing happening with the site anyway. So I don't worry about that at all.
And this next question from Yang Basedong, how did you get rid of the tire patch on the free gingival graft, or do you choose connective tissue graft instead?
Honestly, depending on the aesthetic situation, I love free gingival grafts for their longevity and their predictability. Cosmetically, I prefer the connective tissue graft, but unfortunately, once the tire patch happens, there's no way to really get rid of it. I mean, you can deepithelialize it and and all that, but it still always kind of looks like a tire patch.
This next one from Adriana Costa. If there is a thin buccal plate with a small fenestration due to a chronic abscess at the apex of an upper incisor, is placing an immediate implant an option, providing you can get at least a 3 millimeter gap to the buccal and a CTG can be placed over the buccal plate via a vestibular approach?
Yeah, my whole thing, as long as you can get the implant in the proper restorative position, then it's still a go. As long as I don't like having the apical part of my implant sticking out of the labial plate. So as long as it's still contained within the bony walls, I'm not particularly worried about a fenestration.
This next question from Mustafa Ramal. Are you a fan of osteoplugs?
I've never used them in osteoplug, so I wish I could speak to that, but I've never used it.
This next one from Elliot Deweese. If you need vertical bone gain, do you use any titanium reinforced membranes or still just the resorbable?
Yeah, so Elliot's a good friend as well, a great periodontist. What I would say, Elliot, in a situation like that, we do tend to use more titanium meshes or titanium reinforced if we really, really have to nail it. If we don't have to nail it, then a lot of times what I'll do is I'll use a vertical tenting screw and utilize my resorbable membranes just like I showed in the earlier cases.
And this next question from Alireza Menmadust. When do you remove your titanium non-resorbable PTFE membrane if it becomes exposed after GBR within the first few weeks? In this case, it has been tacked and also patient is keeping the site pretty clean. What's your suggestion?
Yeah, so I don't, I mean, I'm not the expert on that. I don't actually use non-resorbable PTFE membranes, but the general rule of thumb is you know, if it's just like dangling out of the wound, you got to trim it because it's super annoying to the patient. But if it's just a little bit exposed and they're keeping it clean, the big thing you have to worry about is infection. So a lot of times we'll just keep it, you know, we'll just keep it clean. But as you'll see, sometimes it starts off as a small hole and it keeps getting bigger and bigger and bigger to where eventually you might be forced to remove it. But that is complicated once it's tacked or screwed into place. So the goal there is to try to at least get the patient into the 3 or 4 month mark where at least you have some osteoid present, so that can hopefully help you.
And this next one from Brad Leander, outstanding presentation as always. What are your thoughts on long-term outcomes on vertical bone regeneration? Always see this stuff on Instagram, but I would be interested if you had any experience and what your thoughts were.
Bradley, another great periodontist. I would say, Bradley, I don't, I personally am not the greatest at vertical bone augmentation as far as longevity goes. I wish I could speak to that. I mean, I would say I've had cases where I've grown great vertical bone, and I've got a case that I show, in my courses and in my webinars that where the vertical bone's lasting. I'm going on 15 years, and it's super impressive. But I also have some where once we put the implant in and we load it, we get bone loss that mimics the exact shape and size of the defect prior to me grafting it. So I wish I could give a better answer, but my confidence level in myself doing vertical bone growth is not super high. Yeah.
Thank you, doctor. This next one from Roderick Lagunda. Can you please repeat the armamentarium for fat sac procedure? I missed one of the instruments.
I just like that people say fat sack. I think it's really funny. But I use three instruments. It's the number one Woodson. I use a Pritchard elevator and a 4R4L scaler. Yeah.
Thank you. This next one, Justin Noose. What is your take on LAPIP to salvage
Yeah.
implants and promote bone regeneration?
You can't see my blurred screen, but my LANAP certificate is right here. And I got it in January 14th of 2006. So I've been doing it for a long, long, long time. Does it work? It can work. Does it work all the time? No, it does not. Um, it does better than nothing. It's nice and conservative. It definitely um, I definitely you don't have to reflect flaps and all this other stuff. So I believe it's a nice conservative approach. I've never lost a ton of tissue. I've had some good luck. I've had some just not. Let's just put it this way: the patients don't get worse, but they don't all get better.
Thank you. And this last question from Jamin Chin. How do you suture for periosteal stabilizing suture while doing GBR? Since you are
Yeah.
making a full thickness flap, do you go through buccal flap periosteum as apical as possible, perhaps apical to the periosteal releasing incision if you made one? Maybe I need a clarification on lasso GBR technique.
Yeah, so I would say that's probably better with a YouTube search because we do have that webinar as well. If you guys, I believe it's the no nonsense guide. It was the GBR in action or something like that. But like Shirley said, I've got that webinar where it shows you where to loop that suture through. But to answer your question, every flap release when you do GBR consists of a periosteal releasing incision, towards the apical part of that flap. Apical to that incision, you'll see a little bit of periosteum, and that's where you hook your suture through to tie your membrane down. So,
Well, thank you, Dr. Wong. That is all the questions we have. We've gotten through all of them,
is that a
and we
record
are
for
better
questions?
for it. I think so. I think that's certainly my record for the number of questions that have come in. And we had a really high turnout tonight because it was just such a wonderful presentation, and it sounds like fat sack has become a term. So
I
this is
want everybody to
wonderful.
like post it and hashtag it and yeah, like tag me in it.
Yeah.
I would get the
And
biggest.
hashtag you. Yep.
That would be the
I
big
think,
kick out of that. So, thank you
yeah,
all.
very cool. Thank you so much. And thank you, Dr. Wong, again for a wonderful presentation. And thank you, our audience, for joining us. And like we said earlier, we did record tonight's webinar, and we're going to be emailing out that recording sometime in the next week. And we'd also appreciate your feedback via our survey that's going to pop up on your screens shortly. And with that, thank you for joining us, and we look forward to seeing you on future webinars. Have a
This is
wonderful
awesome.
night wherever you are.
Thanks, guys. Appreciate you.
Thank you. Thank you. We appreciate you. Thank you.